Good afternoon, everyone. Welcome to Telemedicine Project Echo. Our topic today is telehealth delivery in a unique managed care population. And I would like to thank our Project Echo manager, Laura Lappy, as well as Mac Richards for joining us and setting this up for us. Joining me here is my colleague, Dr. George. Dr. George is an associate professor from the Department of Internal Medicine, specializing in nephrology. And we are fortunate to be joined today, Dr. George, by not one, but three wonderful speakers who will be talking on telehealth delivery and unique managed care population in the correctional facility. Next slide, please. We will learn today the benefits and challenges of telehealth in correctional facility, discuss the mission of TTUHC managed care, and explain the cost-effective alternative to the technology, as well as understanding regulatory changes, as well as identifying risk management among incarcerated population. Next slide, please, Laura. These are just some helpful tips for our Zoom meeting. Make sure everyone is muted. And if you have any question, kindly type in your questions, and Laura Lappy will be addressing that after our discussion. Next slide, please. So, Dr. George, can you introduce our speakers for today?
Yes. Dr. Santos, thank you for giving me this opportunity to be participating in this wonderful discussion. And today, the three speakers that we have are, one is Dr. Shallow. And Dr. Shallow, she is a telehealth clinical director on managed care, and also West Texas, the Southern Region Medical Director. She's a board certified orthopedic hand surgeon who, prior to joining TTUHC Managed Care, spent 20 years in private practice in a large multi-specialty group in Lubbock, Texas. Then we have another exciting speaker. This is Ms. Rebecca Ramirez. She's the Managing Director of Compliance and Risk Management. Ms. Ramirez serves as an adjunct professor in various law and graduate level courses at the Health Law and Ethics and Healthcare Compliance Regulatory Rules and Standards. Ms. Ramirez earned her undergraduate degree from Texas Tech University and completed her certification in health law and science in conjunction with her health law degree from Texas Tech University again. She also has earned a master's in health administration along with various health and compliance certifications. Joined with us is Mr. Shank, and he is interested in healthcare delivery processes using data science to identify improvement opportunities and technology to facilitate the workflows to realize improvement gains. So without further ado, we just let the speakers give their spell.
All right, we'll get started. Well, good afternoon, and thank you very much for joining us today, and look forward to sharing our experience utilizing telehealth in correctional managed healthcare in our West Texas region. I'd like to start with just letting you know, we'll give a current overview of our telehealth utilization, the benefits, challenges, our growth opportunities in managed care. And before we start that, I'd like to start with two questions that I had when I joined and started this job in March of 2020. The first question was, how do the Texas Department of Criminal Justice inmates receive healthcare in prisons? And my second question was, how can innovation and telehealth help provide healthcare in this high-risk, at-risk population?
Dr. Shallow, this is Rebecca. They're having trouble seeing your screen. It's only partially showing.
Okay, let me see what I can do.
Probably, yep.
This? Will that do it?
No, ma'am. There you go.
Perfect.
That's much better.
Great. Okay.
job.
All right. So I want to kind of give some background and some history of managed care, just to lay some foundation for the rest of the discussion. Since 1989, Texas Tech and UTMB medical schools have been partners working together to provide a mission to give a safe, quality, timely, cost-conscious health care for the inmates in the Texas Department of Criminal Justice facilities. Texas Tech provides healthcare to approximately 30,000 inmates in 18 different geographic locations. And currently, TDCJ is housing inmates in 19 of the 22 facilities that are in West Texas. What do? We meet time-sensitive access to care standards with initial evaluation within 7 days. We address sick call requests within 48 hours to 72 hours. That's weekdays versus weekends. We provide specialty care expedited within 30 days and specialty care routine within 180 days for these inmates. We provide medically mandatory care. That's care that's essential to life and health. Otherwise, rapid deterioration would be expected. And we provide medically necessary care, care not immediately life-threatening, but without treatment, significant risk of serious deterioration could occur. Well, managed care has been providing telehealth since 1994 to assist with the healthcare needs of inmates and to assist with a mission. And our telehealth continues to evolve and to increase. And yes, we do have challenges in providing healthcare to the prison population. Some of them are very similar to what we experience out in the community. The rising cost of healthcare. And as you can see from this graph, you can see the rising cost per day, per inmate from 2014 to 2020. The healthcare costs are increasing and our state budget remains constrained. On this next slide, another concern, the aging inmate population. Many of these inmates' physiologic age are several years older than their chronologic age. You can see from the graph, this is a population over 55 and the change from fiscal year 14 to fiscal year to date. With increasing age, we have multiple chronic care diagnoses, complex medical issues, multiple medications, very similar to what we experience in the regular community setting. Some additional challenges, though, include the geographic location of some of our facilities. West Texas is 50% of our state landmass, and we care for about 20% of the TDCJ inmate population. There's many miles sometimes between the patient and specialty care. Mm-hmm. And transporting these patients comes to a cost with gas, with vehicles, with our TDCJ staffing, whether we go by ground or by air, and the cost ranges can go from $250 to greater than $1,000 per trip. The other interesting challenge in this environment that I had to learn to appreciate is that we as healthcare providers are guests in the Texas Department of Criminal Justice facilities. We have to rely on TDCJ staffing and security for safety, and we have to go by their policies and their procedures to provide safety for everyone there at the facility. The TDCJ security staff, if we have a patient going off-site for a clinic visit, then there's staff that needs to leave the prison facility, or even to bring patients to our medical clinics on site. That requires perhaps the staff to move from their cell blocks when they transport or escort a patient to a clinic or to a hospital. And that is something to consider. And it was a new thing for me to experience, to factor that in. Sometimes there are times when we may think our clinic's going to be full of several patients for the morning or the afternoon, and based upon what's going on with the security and the guards. That may completely change what your day looks like. Now, how are we addressing some of the telehealth barriers in managed care correctional medicine? Well, some of those barriers are the same. Broadband access in rural Texas is a unifying technology barrier, and managed care collaborates and advocates at local and state levels, just like many of you guys on this Zoom. Technology, ease of use for the telehealth providers and presenters. Our IT director is going to speak about this shortly and give some of the things that we're doing now and some of our future plans on how to address some of these issues and make improvements. Payment parity, it's less of an issue. Managed care contracts are structured a bit differently because of the environmental variables that are unique to patient care in a prison facility population. Now, the other variable telehealth literacy, physician hesitancy, and practice concerns of how to provide quality, ethical care. Now, establishing health promoting accurate assessment and treatment plans during a telehealth encounter is a learned skill. Managed care is providing basic training and opportunities to practice the art of medicine and develop efficiency in process and effective patient and provider interactions during healthcare encounters. It's really a great place to hone skills. Finding the balance where we're using telehealth without compromising quality medical care. Well, managed care has developed quality medical and mental health, patient satisfaction, and operational metrics. So what we do is we compare our telehealth results with on-site in-person patient outcome measures, such as our HEDIS metrics for diabetes or for diabetics with blood pressure. We do mental health initial assessments and the need for reassessment within 30 days. Also checking the number of not seen scheduled patients and why they weren't seen. We watch for trends and make adaptations to our plans as needed. Rebecca, I'm sure, will speak to some of that with her compliance expertise. Now, the benefits of telehealth delivery to the incarcerated population. Well, for providers, for starters, we're able to see patients from a safe, comfortable location, whether it's your home office, your clinic office. It provides an opportunity to improve work schedule and life balance and work remotely. There's also decreased patient contact points in physician staff clinics, and maybe some of opportunity to decrease some of the insurance issues that come up that are now becoming provider tiering issues with outcome-driven evaluations. We don't experience some of the issues that happen with insurance companies. So it makes it a little bit smoother for your clinic and clinic staff. For the patients, well, it improves access to specialty care that sometimes would be really limited just because of geography. And their waiting time for next available appointments with an on-site physician is reduced. It promotes patient engagement with additional face-to-face patient education, and that can really promote personal health ownership. We had an opportunity at one of our units where we noticed that some of the HEDIS metrics, one of the diabetic hemoglobin A1C metrics, was really falling out of compliance. And we were able to bring our PharmDs to assist with medication education and our medical education and medication compliance efforts, along with having some additional telehealth go to that unit with additional primary care docs, seeing the patients more frequently, really improved that situation over a 3 or 4 month period. Another benefit for the patients is reduced missed appointments. Many times inmates will refuse medical care because they don't want to leave their home or their personal property that they have in the cell or on their unit. for a medical appointment. They may lose their particular cell, or they may lose the cellmate that they're getting along with, or miss a visitation day or a parole appointment, or they may lose a desired work position from being gone for several days just to make an appointment in Lubbock because they were out in Dalhart. So it has really improved patient satisfaction. For our TDCJ and community stakeholders, efficient, cost-conscious utilization of security personnel and transportation resources is a plus. The safety at the facility for staff and inmates and in our local communities is improved. Telehealth contributes to Texas' relatively low per capita spending on prison health. While our current telehealth service lines and future planning, we have specialty care physicians, primary care, mental health. Mental health has been a service line that we've had for quite some time and is very robust. We're spending time at this point really trying to grow and develop our medical telehealth. We also have teleoptometry, we have PharmDs, we have a physical therapist, and dental is in an early planning and development stage at this time. You can see from this slide an increase in our managed care telehealth, our specialty telehealth currently that's provided. We have cardiology, dermatology, endocrine, GI, hem-onc, nephrology, orthopedics, pulmonology, and urology. Teleoptometry has done 1,072 visits year to date, and that's increased about 22% from the same time period in 2019. Managed care has found that building a telehealth clinical foundation requires physician and health care team engagement, monitoring quality health and wellness outcomes, and adapting when we need to, and being sensitive and focused on patient satisfaction and patient health outcome buy-in. Managed care serves an at-risk, high-risk population, and telehealth is a tool with great potential to assist with providing quality, cost-conscious health care to a marginalized population while we promote health and safety in our West Texas communities. And I want to encourage you and challenge you, those on the call, to consider contributing your specialty skills to this unique form of community service and healthcare delivery. And at this time, I'm going to stop screen sharing and have Rebecca begin to share a bit about our Urac Accreditation.
Thank you, Dr. Shallow. So good afternoon, everyone. I just want to kind of start by telling our story. Can you see my slides appropriately? Thank you, Corey. Corey's my go-to on questions. So we achieved accreditation through Urac in November of 2020. And probably the number one question I get is, well, let me lie. Two questions that we get often is, number one, why would you pursue accreditation? And then number two, why did we choose to do that through Urac? So I just want to tell you a little bit about kind of our mindset going into it, and then how we kind of went through our road to become in partnership with Urac. So when we look at why to get accredited, from my position, it appears that there were two major areas that we were looking at. We were looking at it from a quality standpoint and then a risk management standpoint, or risk mitigation. And so when we look at quality, we thought that as we had done telehealth some sort, including mental health from the 90s. So we've been doing telehealth for a significant portion of time, and we had processes in place, and we felt confident in the delivery of that care. But it does allow us to, with some of the nuances that are present both in person, in traditional visits, along with in our setting, there are some obstacles we wanted to overcome to ensure that we were continuing to provide quality care. And so in doing so, we thought the accreditation would help us in improving some patient outcomes, assisting in meeting the demand, and kind of fostering a culture of quality and safety. Really coming from my background, I'm a big fan of policies, SOPs, and standards. And so we felt that if we had an accreditation that would help us give some validity to some of those processes that we had in place. And then moving forward, really help us in decision making as we started looking at expanding our network, providing other types of telemedicine service lines, and enhancing our technology. And all of this was occurring probably in 2017, 2018. No one even knew we would be in the place where we are now. And back then, there was still some hesitancy around telehealth, more so than we find now. Some of the laws, parity laws, in-person initial visits, some of those obstacles were still in place. And so we were really just trying to enhance and have some affirmation of telehealth services, which would lead us then into the risk management, risk mitigation aspect of it, where we would be able to show through accreditation that we exceed industry expectations. We have contracting power. We think that being able to say we're accredited through this will enhance our ability to develop those partnerships, to expand that network. And validation of systems that were already in place, like technology, privacy, safety, those types of things. And then just promoting communication and staff involvement internally. So again, when we look at why get accredited, we've been doing it, why take this extra step? It was, I would say, due to quality and then due to some risk management strategies. Now, how did we end up with Urac? So we had a unique experience when we decided to pursue accreditation. We wanted to do some research. And so we became active in the American Telemedicine Association, so the ATA. And when we started becoming involved with them, we learned that they had recently ceased accrediting their own members, but rather there was this third-party organization that had been developed, which was the Clear Health Quality Institute, so CHQI. And so they were now a standalone entity that were creating telemedicine, telehealth standards. And part of what we liked about that group is that they actually, part of their standards committee included someone from a correctional health system. And so they actually were taking into account how could telehealth entities participate in the accreditation process. So after some communication going back and forth, we decided probably in late 2018, early 2019, to pursue a contract with CHQI. So we began the application process with them. We're starting to get ready. And then we found out that CHQI was being purchased by Urac. And so we then had to reassign the contract and go through all of that. And then once that reassignment was completed, we were about in 2020. So when we're asked why Urac, through the Yellow Brick Road, we ended up partnering with Urac. But in doing so, we felt confident in continuing and pursuing that accreditation because they were already, I believe they've been an accrediting agency since the 90s. 1990, I believe. And they were credible with other types of accreditations in pharmacy and managed care. And so we felt comfortable going ahead and pursuing that accreditation through Urac. So I would hope if any of you choose to pursue that, your kind of road down to accreditation won't be a 3-year adventure like ours. But we were able to get there successfully. So that's why Urac, and that's how we got here.
So Ramirez, just a quick thing. Well, there you go. Just for the benefit of our listener, URAC stands for Utilization Review Accreditation Commission. So
No,
this is
sir.
just.
Actually, I want to clarify that Urac, that was their former name. And they
Okay.
have clarified that they do not go by that former name. They go by Urac.
Oh, okay. So they don't have the acronyms anymore, but
No, sir.
essentially it is an accreditation committee, just like the JCO for hospital or the DMV, right?
That is correct, yes, sir.
Thank you.
Yes, sir. And the only reason I say that is because I signed something that said we would use the appropriate marketing guidelines. So I want to make sure we're comfortable with that. So it's actually not an acronym, even though it looks like it, I guess. That may be a quiz at the end, so be ready. So an overview of it. So what from there, so when we actually, take away the reassignment and all of that, when we had a contract in place with Urac, we were able to meet with them, and they told us it would be about 6 months. And that was a very fair assessment. So if you're considering that, just know that's kind of the ballpark that we worked with. In doing so, we met with them. They have an online portal for the application process. So any uploading of information was great. There was a narrative section, and there's some other narrative sections with some document uploads. So it was really pretty easy as far as from a technical standpoint for me for uploading. After that initial application process, which I'll talk a little bit more about that in a minute, we move into a demonstration, interview, and credentialing file stages, and that's the second part of the accreditation process for us. And so we went through that, and one of the very first things we had to do in engaging with them was identify which locations we wanted to include. And so we decided to include every TCJ unit that we have, because they all provided telehealth services or they had the capability to do so. So we accredited, our current accreditation includes all of our TCJ locations, which, assist with any type of equity or any concern regarding service being applicable to all of those units. The next thing that we had to determine was what service lines would we choose. So we were, even at that time, we were doing different types of specialty care, just some different things. So we decided to pursue 4 different service lines. The first one is telebehavioral health, and that includes our psychiatry, psychology, clinical services related to mental health or behavioral health. Secondly, we did teleoptometry. Third, we did telechronic care. And then lastly, we did teleprimary care. And I have been asked previously, why did we choose those 4? And we chose those 4 because essentially our department manages the location, the staff, and the equipment at the originating and distant sites of those locations. And therefore, we had the same leadership, oversight, and policies that would apply to all of them. So to be honest, coming right out of the gate, I wanted something that I thought would be easier for us to navigate and kind of walk through. So we chose all locations, and then we had those 4 service lines. So how did we prepare? So we then had to look at, they offer 3 different modules, and I'm going to cheat here because I don't know the other 2 as well, but they have what they call a consumer to provider. And what that is, those are services that are initiated by a patient, and they can take place in a home or other non-clinical setting. So that was one module. The second module was what we are under, which is provider to consumer. And what that means is initiated by the provider, and it can take place in a clinical or a non-clinical setting. And then lastly is provider to provider. That's typically going to be more of a specialty consultation, and those usually take place in a clinical setting. The reason that the module is important is part of the standards that you will be asked to pursue, or that we had to ensure that we were meeting, are specific to your module type. So again, we were selected, correctional healthcare tends to fall into that second category of that provider to consumer aspect. So we did have some standards that were related to that. When we go into the standards, you're looking at some broad topics. There are about 5 major areas that they look at. And there is a total of about 30 to 35 standards. And they're going to be looking at business requirements, professional oversight, clinical workflows, quality and patient safety, and then risk management. And then they'll go into those P2C, so the provider to consumer specific standards. And that's where you're looking more at program goals, technology, proficiency, the outcomes, education, those types of things. And again, those are specific to those modules. We also had to formally name 2 key positions. So we had to name a telehealth clinical director, which is in the role that Dr. Shallow holds, and then a technical director, which is the position that Mr. Shank holds. So we formally submitted those CVs and those positions and those titles. They were required as part of the accreditation. And then when we look at obstacles, so I would love to sit here and tell you that it was a breeze and we had no issues, but that would be nothing but lies. And so we did, we were doing well. We, again, had been doing telehealth in some form or fashion since the 90s. We did it well. We felt we had good processes. What we were missing is policies and standard operating procedures and documentation of a lot of the processes that we were doing. And so an example of those would be those program goals and measurable objectives. And so we might have a strategy, we might have some goals, but we weren't necessarily a formalized process where we were like, okay, every beginning every fiscal year, we're going to establish these goals and we're going to have a measurement for every month and so forth and so on. And so even though we were goal setting, you know, we certainly wanted to expand our network. We wanted to pursue specific areas that maybe we were having or approaching access to care issues. We hadn't documented those processes or SOPs. So we did have a development of those items as part of the accreditation preparation. We also had to kind of enhance our documentation related to the effectiveness of our services. In particular, they wanted quality indicators that were in 3 categories: operations, clinical services, and patient satisfaction. Not only did they want those, they wanted to see a specific outcome, what were our related goals, the progress along the way to those measures, and then any caps or corrective action plans that were in place due to underperformance. And so we were measuring that in different ways. The key part that we were missing is comparison to traditional modality. And so now, as Dr. Shallow mentioned, we're very deliberate in gathering that information, showing the progress, any corrective action, but then also doing a comparison to our traditional modalities. So that way we can really ensure that we're providing quality services through both modalities. That being said, I am working on always talking about strengths as well. And so we did have some things that we knocked out of the park, to not be humble right now. And we had amazing providers and presenters that had been trained and were doing their jobs and duties really well. So that piece of it was really easy. Mr. Shank and his team had really enhanced our abilities technically, along with reporting wise and what information we could extract. And so we could easily, I say easily, we could work with his team and say, okay, these are the goals, these are the measurements, these are the metrics, and they can help us get that. And then lastly, we utilized the Health Sciences Center's policies related to security and those types of things from an IT perspective, and those certainly were an amazing strength. So those I would say were probably our top 3 obstacles along with our strengths. So we went through the application. There are 35 standards that I talked about earlier. We went through that process. We uploaded, we did narratives, and we were surprised. We thought we might have, you know, some things that they wanted us to change, but they did not. We were told that we had met 100% compliance there. And so we moved on to the demonstration and the file review. For the demonstration, we chose not to do an actual patient visit. Rather, we did a simulated visit of the different service lines. And Mr. Shank can tell you a little bit more about it if you have any questions, but we set that up. We were doing at that time telemedicine services through Real Presence. And so we set a second video and camera so they could watch both the provider's side. So it would be over here by me, and they could see the utilization of the EMR, the setup for the provider. And then we had another camera set up at the patient side, and they were able to see the utilization of the peripherals, utilization of the consent processes, the setup of the room. And they had really positive feedback. That was the first time they had done it in that manner. And our rep actually told us he wanted to see if they could do that with others. So we were excited about that. We were also interviewed, all three of us, Dr. Shallow, Mr. Shank, and myself were all interviewed just along those areas of our follow-up questions related to our areas. And then lastly, they did a file review, which essentially we got in a Zoom meeting, and the rep got on with me, and we went through credentialing files of each of our providers that was covered under the service line. And so we looked at background, licensure, sanctions, exclusions, all of those. And so we went through that. And then on November 1st, we got our accreditation. So we were super excited. So after that, so we can't just stop, right? So we need to continue going. So we have, all of our SOPs are in a nomenclature. We now have them on the review schedule, and we've only added, I believe, one since the accreditation. We have an SOP now related to new service lines. And so it's certainly nice to be, we have a formalized telehealth committee that helps with our planning and strategy. And so it's nice to be like, oh, do we need an SOP? So even our thought process of documenting all of this is very different. And the telehealth committee really helps us align with, okay, we're approaching the fiscal year, and it's time to set those goals. It's time to open or close some of those measurements. Documented training. So we did training for our providers and presenters, but we're on an annual schedule now. And so we're ensuring that everyone has onboarding training as well as annual training that's documented. And we're actually just now going to transition, I think, to Sakai to even enhance those processes as well. For our next audit cycle, so we will start in 2022, which is next year already, a year out. And we will start gathering documentation. They have let us know that our standards will be different. So if you choose to pursue this, we kind of were grandfathered under some of the CHQI standards. And so we will pick up, I think, a different set of standards, which I'm not concerned about, but just know that we know going forward that will be a little different. And so as we look at expansion, Dr. Shallow mentioned this, that one area that I do foresee, if everything goes according to plan, is that we will implement teledentistry. And I would like to include that as part of the scope in our reaccreditation process. Some of the things that have to occur there first is finalization of the dental board's rules and kind of board rules that they'll publish. We'll do some revisions to some consent forms and then develop an SOP. So at this point, I will stop sharing and pass it off to my colleague, Mr. Shank.
Well, thank you, Rebecca. And thank you, Dr. Shallow. And thanks, everyone. Share my screen real quick here.
Corey, while we're waiting for, well, you're quick, but
no, go ahead.
I think Ms. Ramirez and the team of the managed care have foresight, because I think this will be the wave of the future, accreditation, in order for not just for prestige, but as well as for quality as well. I think you guys have a foresight. Then eventually I'm thinking right now it's not required, but I think in the future, everyone who will do telemedicine may have to do this accreditation. So you're ahead of the game.
Thank you.
Okay, well, I'm going to go into my section, and kind of how I got into this was started and worked with our IT, and one of the first things we noticed was that our carts were coming out of warranty, and so I had to replace them. And we had like 8 comprehensive carts and maybe 20 cameras where we were limited to only behavioral health. And when I got the price tag of about $25,000 for replacement, I don't know if you all know, but TDCJ Healthcare Services is the most managed care capitated healthcare environment in Texas. There's a fixed budget and everything has to be spent within that. And so there's no billing and there's no collections. And so there's no opportunity to increase your revenue. And so if your costs rise and your budget doesn't rise with it, you have to think differently. And so we looked and we went to our vendor and got quotes. And then I started looking at the technology and we realized that we could recreate our carts using modular systems. And that's where the modularity comes in. And so we built our own carts for $3,000 each, which is, it's 12% of the cost of each cart. And because we were able to do that, we now expanded to have comprehensive carts in 35 different areas. We have 20 or so units, but some of those units are very large healthcare delivery systems, infirmaries, and clinics. And now we were able to expand. So we went from 8 comprehensive carts to 35 comprehensive carts. And a comprehensive cart includes a stethoscope, an otoscope, and exam cameras. And so we went from having 8 with those items to now 35. And we needed to do that in order to meet our equity that were for Urac, as we couldn't treat one patient differently. And so we need to expand those resources. With that, the expansion with this accreditation, there's always a reason you get accredited. It's because you want to expand your services, right, Rebecca and Dr. Shallow? And so by doing that, cost reduction was allow us to expand. We're not just expanding our footprint with the 35 carts, we're constantly expanding our peripherals and our capabilities. Our peripherals have allowed us to expand our specialty care that Dr. Shallow talked about, which is a huge thing. And she mentioned the reason why it's huge is because the access to our patients for specialty care is very difficult. And so by being able to do that was very helpful on the expansion side. And then once we were able to identify, that we could literally go buy a cart without thinking twice. It's almost not even a capitally covered, capital expense. It's so cheap. We wanted to look at how we could continue to be prepared for the future. And the bullet here for lessons from real presence, when I started looking at that, and you all may know, if you're from the university, Vince Fell, and one of the things they're working on is converting from real presence. And we were one of the last stakeholders of real presence, to be honest with you. But when we looked at it, we found out that the provider experience, and for us, we always talk about patient, not us, as providers, you're always focused on patient experience because you're less concerned about your experience and you're more concerned about your patient's experience. But for support teams like IT, we're focused on provider experience. And with real presence, in order to have a provider see patients, they would have to dial directly to the unit or the IP address to real presence. And so a lot of the administration process fell on the provider's hands. And one of the things that we get from Dr. Shallow, which is exactly what we want, is how can we continuously make this process easier for our providers, the barrier to entry to be lowered. And so we wanted to make sure that our platform, we were going to actually allow the providers to have a simpler process with Zoom, where they can just start their Zoom clinic and the presenters will actually connect to them. And that was a lesson from real presence. Another lesson from real presence is we actually provide telehealth connections with non-university specialty care providers. And so it's really difficult for those outside of the university system to get real presence, to get a vendor e-rater and get everything they need to meet the security requirements. It became a barrier to care. And we're with Zoom and all of our future modalities, it just makes it so easy. We create a URL. They log into that URL, they manage their clinic, and we can now go out and talk to our other partners in the communities and open it up for them. And then the extensibility is with the way we've set up our carts, they're non-proprietary, and with the way we've set up our technology system, it's non-proprietary. We do some business with Hendrick Medical Center and Mitchell County Healthcare System, and they don't use Zoom. We work with UTMB, which is our partner in TDCJ, and they use Microsoft Teams. And so one of the things that we're really focusing on moving forward is not just committing to Zoom, but committing to a non-proprietary system. So if we can engage a specialty health system or a specialty provider who uses a different modality to ensure our hardware and technology can maintain compliance, support, and delivery. And so with our new systems, we're able to, when we plug in a stethoscope, we can convert the audio through a codec and have it come in through the Zoom or the Teams environment instead of a third or second system. Our exam cams are presented through the same environment. It just makes it so much easier for our providers. And that's really all I have to say is one of my #1 goals is to never have the process to entry so easy that our physicians and providers seek us out as an opportunity to provide care. Because sometimes when you think about, oh, I got to click this and I got to have this open and this, that, I wouldn't want to do it either. And so that's what we're working on, is to make our provider experience much better. And with that, I'm done. And here we go. Questions and answers. Dr. Shallow?
So thank you. And I first question is to anybody. Dr. Shallow, the question is, are teleservices only provided by Texas Tech physicians, or are there private providers too who provide services?
Sure, good question. We have Texas Tech physicians, specialty providers, and mental health providers that often help us, but we also do have folks in the community that are contracted to help us out as well. And it is a joint effort. We really like to partner with our various schools. School of Nursing helps us out with some primary care, along with our PA school and schools of medicine in Midland, Odessa, and Amarillo. But yes, we also do have some contracts with folks that are in private practice or private groups.
And so I have some question for Ms. Ramirez and Mr. Shank. Now, this being a special population, are there very specific equipments used in telehealth? And how do you incorporate this in the private setting, taking into consideration the confidentiality and HIPAA issues?
I'm sorry, may I ask you to repeat that question again?
Now, you're addressing medical health in a very specific target population.
Yes, ma'am.
And this being a special population, are there specific equipments used in telehealth? And how do you incorporate this in a private setting, taking into consideration the confidentiality or the HIPAA compliance?
So our telehealth services occur in clinical locations, same as traditional. So they occur in the same private setting and have the same confidentiality requirements that our traditional visits have. So we don't treat them. The only difference is it's a machine versus Dr. Shallow in the room. So we've actually continued to ensure that those are in exam rooms or other clinical locations at the prison, and therefore we tend not to have any concerns there.
Yes, and in terms of equipment, the only special equipment is the telehealth equipment that we continue to seek to add to our stable of opportunities with the cameras, the stethoscopes, and the otoscopes. And actually, we just yesterday and today we're thinking about potentially pursuing tele-ultrasounds to be able to help our specialists have the access to the diagnostic information that they need to be as successful in this environment.
That is all great idea, Corey, by the way. I know Corey for 3-4 years now, and he's an innovative, creative, manager. And there's a question there actually in the chat box, Corey, regarding if you could make your own cart. And I think you kind of partially answered that question.
Yeah, for sure. I mean, when we looked at the carts, the first thing we noticed is they're nothing special. The only thing special about them is they weigh about a ton. So unless you need, about 500 pounds at the base of the thing because you're afraid you're going to tip it over. Other than that, it's a PC with a USB port, 4 or 5 of those for your peripherals, a good quality camera, and good quality speakers. And so with that, that's all you do. I mean, if anyone wants to know, I can share a photo of ours. It's very basic. It looks more like an AV card. If you were in the AV club in high school, it looks like that. It's not, but it works. And the cool thing is when we need to upgrade a PC, we don't spend $30,000 to replace just a PC. If all their peripherals are good, you just replace the PC. If the monitor goes out, you replace the monitor. If the camera goes out, and we do pay very close attention. I mean, we're not under the same CMS guidance for billing and collections, but we do follow all the same policies for FDA approval. So our stethoscope is a direct USB connection, but in order for it to meet the FDA requirements, it has to run through a software codec. And that codec actually converts it to the correct and highest quality, and then pushes it through our Zoom or Teams environment. And none of this, I don't own a company. And I think that's the good thing is I'm not a salesman. So I'm happy to tell you guys everything you want to know. But they're about, the stethoscopes are like $250 and the software is $30 for a forever license for that device. It's very inexpensive. And I find that our providers really enjoy that. And the thing is, if you want to be effective, the only thing you ask on the provider side is, wear a headset, because if you're going to use the audio diagnostics, you really want to be able to have a nice headset on your head to hear. I mean, I'm not a doctor, so I can't tell you what to listen for, but I can tell you it's hard to listen to it out of computer PC speakers.
So for managed care, it's important to mitigate expenses. So has teleservices helped in cost containment?
Yeah.
I mean, who wants to answer that? But the answer to that is yes. There's a lot of things that we reduce hospitalizations sometimes because sometimes our primary care, or not primary, but our specialty care is done in hospitals because of our environment, at least traditionally. But mostly, it's just the transportation. We used to have a process where if someone needed to go see a specialist, even for a consult, we'd have to drive them maybe 3 hours to Lubbock. And that's an extreme cost to the taxpayer. And now they don't have to move. And that's my answers. And I'll let Dr. Shallow and Rebecca probably answer more appropriately.
And I don't know if you guys know that whenever they transport a resident, I think that's the term now they're using, is they need 2 guards to transport them at least.
Yes, sir. And actually, they can be 4 hours away, but it could, for example, someone coming from El Paso to Lubbock for services, literally it takes 3 days because they have to stop at hubs and spend the night to get here. So those resources certainly are much more expensive. And then when you look at some of the other measures as far as safety and those other things, but it's Dr. Shallow, I'll defer to you, but it's a big yes for me that we have cost saving measures for sure.
Yes, absolutely. Safety and cost savings for sure. I think there was, just like as I referred to in my presentation, they had done a study, I guess it was even in 2011, how the nation's largest prison population, which is Texas, Pew Charitable Trust, said that we spent about $3,800 on prisoner medical care in 2011 compared to the national average of about $6,000. So I think telehealth is contributing to that. And we've been aware of that because telehealth has been around for quite some time in our Texas correctional medicine care.
And also those that, again, going to what Dr. Shallow said with the access to care, they're more readily, we certainly see an increase in those willing to participate via telemedicine. And so therefore they're engaging in healthcare earlier. And so then maybe you're not having some of those more expensive, more severe acuity stages later on. So
Dr. Shallow, you know that I'm from the Department of Surgery. Dr. George from, Department of Internal Medicine. And I saw Dr. Winkleman there, who is from the School of Health Professionals. And we have Marco Guardiola earlier on from UMC. What are the things that we could help you with in delivering healthcare or telehealth care? Something that we could collaborate with managed care, the Office of Managed Care.
As I said, it is fabulous to have you folks be willing to share their specialty skills. For you as a general surgeon, realizing that, okay, you may end up seeing your patient and operating on them at the hospital, but you can do your post-op follow-up sometimes via telehealth. And you may be doing that already in your clinics, but it is absolutely a big help to be able to not have to move the inmates, because it is a real drain on resources. And Rebecca's absolutely right. Sometimes the inmates will sign a refusal of care because they don't want to make that long trip from Fort Stockton to get stuck in Abilene to finally make it into your office to see you. And then they have to go back to Abilene, however long that takes to get them back to their home or unit of assignment in Fort Stockton. So yes, just realizing in your field that there are ways that you maybe could incorporate telemedicine. I understand sometimes your initial consultation, you need to see them and touch them, but post-operative care, that's an option. All sorts of options. Just folks being willing to share their expertise with managed care would be a big help.
And Dr. George here, who's a nephrologist, could manage dialysis in the prison system, right?
That's right.
Putting you on spot, Dr. George.
On that lines, I have one more question. How are we able to deliver continuity of care when multiple entities are involved?
Great question.
That's a really good question. And for our specialist in particular, we make sure that if a patient has been seen by a specialist via telehealth, that we have the process set up that, let's say you saw the patient, you wrote your note, it got sent to our system so that we could put it in our EHR. A nurse is going to check and make sure that that note is there the next working day, and an appointment is scheduled 3 days later for someone who is providing care at that unit where that patient is, whether it's a APP or an MD, to see that patient, talk to them about their telehealth visit with you, and make sure that whatever orders you ordered as a nephrologist, whatever labs you need, your next appointment, or whatever test you've ordered gets scheduled. And that's how we kind of keep up with that continuity of care.
Yeah, I think as a non-clinician, it's kind of impressive what TDCJ does with our healthcare services at managed care, because, in the free world, the patients are kind of on their own, and we really force sometimes, but we have a really good primary care environment. And so the primary care provider doesn't lose, they're involved in the care of that patient through all specialty and non-specialty. And so what Dr. Shallow was saying, to me, it's interesting because you just learn about this, well, that's pretty cool. I wish everything was like this. Like when I go see my PCP the next time, they're fully aware and they're understanding of everything that happened in your specialty visit.
All right. Thank you very much, Dr. Shallow, Rebecca, Ramirez, and Corey Shank for the excellent presentation. And congratulations for the Urac Accreditation, as well as congratulations for providing quality care to our prison population since 1989. Just a quick reminder to make sure you fill up your session evaluation, and that's your session evaluation, so you could get your CME points. Any questions from the crowd? Next slide, please. Next slide, please. Another one. So Dr. Shallow, another one, Laura. Corey and Rebecca, as a token of our appreciation, will be presenting you this challenge coin. You will receive that very soon. It's in the mail. And
actually, I've got a little elf at their offices that will deliver it to them once the session is over with.
There you go. Expedited, just like telemedicine. And also, we're presenting a challenge coin later on today to Dr. George as well. Thank you very much. It's a pleasure having you here.
Before we leave, I just want to tell Laura Lappy, thank you so much for everything you've helped us with over the years and how you continue to help us. you're just a great partner to work with, Laura, and I hope I just want Dr. Santos to hear that.
Well, thank you very much, Corey. It's been
You're
an
welcome.
adventure.
Yeah, for sure.
Thank you very much, Corey, for stating that. I thank Laura for setting this up for us. She's very helpful. And Dr. George, next slide, please. Next month, September 23, 2021, we will have another telemedicine project, Echo, and hopefully you will join us, again, if possible.
Thank you for the invitation.
And the topic will be improving access to telemedicine for patients with disabilities. Again, Dr. Rodriguez and Angie and Dr. Winkleman, thank you very much for all the questions. Thank you very much, Dr. Shallow, Ms. Ramirez, and Mr. Shank.
All right, thank you, guys.
Thank you.
Guys, appreciate you.
All right, thank you.